Good evening and welcome to Doctors on Call. I'm Dr. Ray Christensen, faculty member from the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School Duluth campus. I'm also a family physician at the Gateway Family Health Clinic in Moose Lake. I am your host tonight for a program on diabetes. Remember, the success of Doctors on Call is dependent on you, the viewer. Please call in your questions tonight or email them to ask@pbsnorth.org. The telephone numbers can be found at the bottom of your screen. Our panelists this evening include Dr. David Hutchinson, a family medicine physician with St. Luke's Lester River Medical Clinic, Dr. Jason Wall, a family medicine physician with the Duluth Family Medicine Clinic, and Dr. Mike Van Scoy, an internal medicine physician with Arcos Health. Answering the phones tonight from the medical school are medical student Tommy Gentle from Baudette, Minnesota, and staff members Katie Johnson from Duluth and Linda Liskowitz from Duluth. And now on to tonight's program on diabetes. Good evening, gentlemen, and welcome. Dave, tell us a little bit about your practice.
Currently working with the St. Luke's Health System at the Lester River Medical Clinic as a family doctor of 30 years.
Dr. Wall?
Good evening, Dr. Christensen. I work at the Duluth Family Medicine Residency. It's a University of Minnesota program, and I have the good fortune of working at both St. Mary's and St. Luke's.
And Dr. Van Scoy?
Hi, Ray. Mike Van Scoy here, working care management as a medical director for Arcos Health. It contracts with Blue Cross Blue Shield of North Dakota for Medicaid expansion and Medicare Advantage folks.
Thank you all for coming. It gives us a wide base to work off. Dr. Hutchinson, what is diabetes?
Succinct and to the point, diabetes basically is an inability to control one's blood sugar. Blood sugar, glucose, is necessary for the energy and reactions in every cell in our body. And nutrition that we take in is converted to glucose for that energy. The pancreas produces insulin and secretes it in response to when we eat in order to keep blood sugar from rising too high. And there are really two kinds of diabetes, but the common theme between them is that we are unable to control our blood sugars when we're diabetic without some other assistance.
So, Dr. Wall, what are the two types of diabetes that we're going to talk about tonight?
There's a type 1 diabetes, otherwise known as insulin-dependent diabetes, and then type 2 diabetes, somewhat known as non-insulin dependent. And classically, your type 1 diabetic is going to be somebody who's younger, and due to illness and autoimmune, they're going to need to be very diligent about checking their blood sugars and injecting insulin on a daily basis. Otherwise, they become sick with the condition. They become acidotic, and they have ultimately a condition called diabetic ketoacidosis, and that can be fatal. And the type 2 diabetic has more of the, there's a wide age group, but that is our classic, that is where most Americans and most of the patients that we take care of fall into. And they have, a lot of these people will be taking insulin, but they don't necessarily need it. It wouldn't be rapidly fatal if they were to miss it. And there's a whole pharmacopoeia of medications, injectable, oral, and to treat this condition. So think of type 1, you need insulin to live, and type 2, you often need insulin to control it, but you become sick more slowly if you don't have that daily insulin.
Very good, thank you. Dr. Van Scoy, before coming in, you were actually doing some looking online with some of the outcomes of diabetes and the concerns that we have with chronic diabetes. Do you want to tell us a little bit about what you found?
Right, no, thanks, Ray. For sure, you know, this is a public health issue for all of America. We have a high prevalence, meaning the frequency with which diabetes occurs in our population. If you hit the age of 65 and you're on Medicare, you find that 30% of people in Medicare have type 2 diabetes, what Dr. Wall was mentioning. And of those, most of them have complications already due to diabetes. The complications can be poorly functioning kidneys, poorly functioning nerves, vascular disease, which increases your risk of stroke and heart attack, and poor vision. So 20% of people in Medicare have diabetes with complications, and 10% have diabetes without complications by the age of 65.
I think we could even add a little bit that the incidence of even type 2 diabetes, which is largely genetic but also closely associated with obesity and degree of obesity, more and more younger and younger people, even children, are becoming type 2 diabetic. Because
That's
of
right.
nutritional factors and environmental factors, and lack
We-
of exercise and our general lifestyles.
I couldn't agree more. Absolutely. There, in the Medicare Advantage population, 10% of people have either severe obesity or morbid obesity. Severe obesity is, a BMI, body mass index, of 35 or greater, and morbid is 40 or greater. But David, to your point, half of people in America are overweight. 50% are overweight.
Right.
And if you were to have prediabetes, which is a common precursor, very common, before people develop diabetes, the National Diabetes Prevention Program reduces your risk of evolving into diabetes by 50% over a 10-year period of time. And so a lot of that focuses on healthy living and choosing the right foods that are really of high nutritional value for yourself.
Even though the incidence of diabetes is rising and it's more and more of an epidemic, it's really true that we have more and more hope now with intensive management tools, both through lifestyle counseling and adjustment and medication use, to really manage it so much better than we did 20 and 30 and 40 years ago. It's not a, well, there's much greater hope for fully active lifestyle and for avoiding those complications that you alluded to now with current management tools.
Being not the youngest one here, and thinking back to the 60s, and if you go back and look at the pictures from the 60s and the old yearbooks and any of the films from the 60s, we were a different population then.
Boy, oh boy, isn't that true? Yeah.
And I don't know what the numbers were back then as far as diabetes, and I don't remember in practice just how prevalent it was. I knew the juveniles, the type 1s, but the type 2s, there weren't that many, but that's evolved over time. So Jason, you've got let's take a type 2, a new type 2 diabetic comes in. How are you going to treat them? There's a lot of things. I can't give you 20 minutes to tell me, but you can give us a little bit here.
Thanks, Ray. Well, ideally in medicine, our partnership with the patient, they do exactly what we want them to do, and we know that's not the case. It's kind of it's a partnership. And so first is lifestyle, exercise, reasonable diet, and then our first go-to medication is called metformin. And then beyond metformin's a medication that can cause some weight loss. It causes the your blood sugar to, you can lose a little weight, and it affects your pancreas so that your blood sugar doesn't rise so quickly. And beyond that, there are probably 6 or 7 medications you could go on to. If somebody's blood sugar is really high, we'd often start them right away on a basal insulin, long-acting once a day. We'd start them on some of the newer medications that are called SGLT2s, other group of medications, GLP-1s. I can use there are a number of trade names. You'll see them on TV. And then there are some of our old tried and true drugs like sulfonylureas that we would use as well. But it's really going to start with education, lifestyle, and then an ongoing relationship with your primary care team, meaning potentially your physician, your pharmacist is often involved, and perhaps even a dietary or a health coach.
A lot of difference in price in those medicines too.
Yeah, I brought the prices in case anybody asked, but yeah, they're of course, price is usually determined by insurance copays, but the new ones are not inexpensive.
No.
Yeah.
Mike, why is it important to control the blood sugar?
Well, that's a great question. Health Partners, which is a great health system based in Bloomington, Minnesota, produced a report whereby in controlling blood sugars, they were able to reduce the number of toe and foot and leg amputations, and they were able to reduce the number of people moving on to dialysis with kidney failure. They reduced the number of strokes and heart attacks and blindness. So it was not just reducing mortality rate, but it was also improving the quality of life. And it's just a reflection of the fact that when you've got too much sugar circulating in the bloodstream, it almost caramelizes. I don't know if you guys think about being at the grill and looking at what happens when a layer of sugar kind of is on top of your food. It caramelizes and damages the lining of the nerves of the blood vessels and other structures. So that's why it's really important to keep it down. You can show that people live, and people live better.
Being we brought the word foot in, some kind person actually sent us an email ahead of time, and certainly we encourage you to send emails for questions, especially good when we start our discussion. But this was about the Charcot foot. This gentleman had a Charcot foot, saw an orthopedic person and was treated with an orthopedic boot. He wore it for 6 months. The foot was felt to be stabilized at that point, and now he just uses an insert. And the questions are, what is likely to happen with that foot again? Is this likely to show up on the other side? And are there things that he can do to preserve and keep this from happening? So that's a whole bunch of things. Hutch, what are your thoughts?
So Charcot foot in general is an uncommon advanced complication from diabetes, which usually evolves through loss of proper innervation in the foot, and then by some ways that are complicated to explain. Proper innervation is important for the maintenance of bony posture in the foot, for the bones' position relative to each other. And this unusual complication can lead to the collapse of the structure and positioning of those bones. And it's very painful, and it's deforming, and it alters one's physical activity ability. It's very serious, and often treated with bracing, as the gentleman referenced.
So Jason, as long as we're with feet, why do we always look at feet? What's important there?
As Mike had mentioned, the main microvascular, meaning small vessel damage from diabetes, is your eyes, your kidneys, and then your nerves. And so when you can't feel your feet, you kind of get this stocking glove, like it can be a numbness, it can be a burning pain. And so if you don't have proper feeling in your foot, you can imagine that you're going to have skin breakdown, you're going to have foreign objects that could get stuck in your foot. But essentially, you're very prone to developing ulcers on your feet. Not to mention, there are the blood vessels that supply nutrients to the toes and the foot can be compromised by diabetes, so there's less blood flow. Right. And we have ways of testing for that as well. It's called an ankle brachial index. And so, there's nerve damage, there's less blood supply, so you have chronic. It's very easy. One toe stub, one splinter in your foot, and it can develop into an infection and a chronic ulcer. And that's why we're always looking at the feet, because when you have diabetes, the risk of losing part of your foot, amputation, infection is quite high.
With that reduced circulation, healing becomes more difficult, and we pay a lot of attention very frequently in clinical settings to any wounds on the foot of a diabetic, because foot ulcers don't heal very well, and we can't really stop walking, so we keep putting mechanical pressures on those wounds, which increases the difficulty of healing. And as Dr. Well alluded to, the ultimate goal is amputation prevention. Loss of part of a limb was a really common complication in diabetes 30 and 40 years ago, and it's uncommon now because we do so much of a better job at specialized wound care and preventive foot maintenance.
Yeah. And there are Minnesota's and many states where like every diabetic visit there's a checklist of, you know, have they had their eyes checked, have they had their kidneys checked, have they had their feet checked. And so I think we've gotten more systematic, and so that's, you know, it's not perfect, but we're at least aware of the issue.
My lesson is when I took the shoe off and saw the thumbtack and the hole in the foot, and absolutely no feeling. So it's very, very important that the shoes be looked at, that people are very careful. And here's where the eyes come in, and here's where all the rest comes in.
And you made a good point about the shoes being proper. Proper fit is really important in diabetics, because abrasion and friction, and if you have decreased sensation, you don't know necessarily that that's happening, as you were saying, and those can lead to wounds that people aren't even necessarily aware of. And they may be aware, but they don't hurt very much sometimes, and so.
And probably all of us at some point in our practice have had a poor patient come in with a diabetic needle in their foot that, you know, they were injecting their insulin, they accidentally dropped it, and it ended
Stuck
up
in
in
the
their
carpet
foot.
and-
Yeah,
Or there's somebody sewing in the house.
yeah, because you just don't feel it.
Mike, you've been out of this discussion. Anything you want to add into this one?
No, I totally agree with the discussion. I'm still sort of stuck on your description of the 60s, and I think you might be offering us a picture of yourself from the 60s maybe one of these days.
160 pounds.
Okay, you see, there you go.
Then there was internship, and then everything went to pieces after that. A1C, there's a whole lot of questions coming in on A1C. One of you guys want to tackle what an A1C is? Mike, you've been quiet for a while.
Sure, thanks. Hemoglobin A1C basically is just sort of a blood test that gives an indication of what the average amount of sugar level is in your blood over the past 3 months. It's a glycated hemoglobin, so hemoglobin is a protein, and when it's permanently attached to a glucose model, it becomes a glycated hemoglobin, and that's the blood test that we measure. So now, Dr. Wall was mentioning that in Minnesota we've got a checklist of best practices. In Minnesota Community Measures, which is our state's data warehouse of best practices, they like to see a hemoglobin A1C less than 8. If you're in the world of Medicare Advantage, and you're being measured by HEDIS standards, they say that a poorly controlled diabetes is a score greater than 9. So you have some disparity between what people consider to be optimal control. Here in Minnesota, we generally like to have it less than 8 if we can. That having been said, it's just an average value. And if I had diabetes, I could be living in the 60s and 70s, and then way up to the 240s, and still have an A1C of 7.8. So I might look good on that blood test, but half of the day I'm really low, and half the day I'm too high, and I'm really not healthy at either way. So Dr. Wall is going to be asking his patients, what are your morning sugars? What are your before lunch sugars? What are your before supper sugars? And what are your sugars before you go to bed?
Those are all important. The A1C is such a wonderful tool because it lets us look at an average blood sugar over 3 months, right? Instead of a blood sugar at one point in time, at least in the doctor's office. And so checking that average blood sugar frequently gives us a good idea of what's the average level of control. But of course, you're right, the day-to-day variations, especially in type 1 diabetics when blood sugars can vary so widely, that highlights the importance of monitoring at home in different ways as well.
It's also made diagnosing diabetes easier. Back in the day, you used to have separate values on separate days, and
a glucose tolerance test.
I wanted to. One of the most exciting things that I've seen, because people just don't check their blood sugars, and we now have, they're called CGMs, continuous glucose monitors, and some of them transmit directly to your phone. There are some out on the market that you can link to all your relatives, you can link it to your pharmacist, your physician. So the day is very close where you will just have to put a patch on and you won't have to be poking yourself anymore. And that gives us such invaluable data to say, hey, you realize every day between 6 and 9 your blood sugar is way out of control, let's do something about it.
and for continuous glucose monitoring has been so important for type 1 diabetics to help avoid episodes of blood sugars that go too low, which is instantaneously dangerous. But
Why is it dangerous?
well, our brain has to have glucose to function, and if our blood sugar goes too low, we become comatose or have a seizure, or and we fall and hit our head. So we have to have adequate blood sugar, and but we don't want blood sugar that's too high, which is why insulin is also important. Internal insulin from our pancreas is also important. What's been so fun and interesting in primary care practice with continuous glucose monitoring for type 2 diabetics, who normally, depending on what medications they're on, normally don't have to fear that hypoglycemia, low blood sugar, nearly as much as type 1s do. But the continuous glucose monitoring lets them flash their phone over that patch and they can, it's a great source of self-education. You can tell what your blood sugars do in response to what you just did or what you just ate. It's immensely educational, rather than having to poke your finger, which we don't get supplies to do more than 4 times a day. With CGM, you can check your blood sugar multiple times a day.
Yep. And it alerts you if you're going too high or too low. So especially for children too, it's incredibly reassuring for parents to know that, they can just look. Their child can be 10 miles away across town, and they can just be like, "Yep,
Right.
Jimmy's doing fine."
So can a diabetic ever get off their medications?
Yes. The short answer in type 2 diabetes is yes. In type 1 diabetes, people have to be on insulin.
There's no way out of that one. That's right.
Yeah.
So, and how do you do that? David.
May I?
Wait, one of you can do that. Go ahead.
Well, there are...
Then we might shut you down for a while.
Please do, because I'll just go on and on. Dr. Wall alluded to some of this. Lifestyle adjustment is the general way to control blood sugars without medications. But that really entails about 4 different things. You can exercise and burn calories and lower your blood sugar. You can eat less, take in less fuel, and have less ability to generate high blood sugars. You can eat different kinds of foods which are less likely to raise your blood sugar, the so-called lower glycemic index foods, and that's an important part of diabetic education in the clinic and in nutritionists' offices. When people are diagnosed diabetic, it's important to learn what foods are less likely to raise my blood sugar, namely proteins and fats rather than starches and sugars. And fourth, and as important as anything else, separate from all of those things, you can lose weight. So losing 10% of your body weight improves your body's ability to respond to its own insulin in a much more ready way. So we don't need as much medication, or sometimes not medication at all, at a lower body weight, because our insulin is then working better.
Some quick questions, because we're going to run out of time. Jason, what's prediabetes? How is it defined?
Prediabetes is defined by fasting blood sugar at right around 100 to 126. It's just below, I think 126 is the diabetic cutoff, and there's an A1C range. I think it's 5.6 to 6.4. You're asking me, but anyway, it's basically if there's a bell curve of diabetics, it's that group of people that are trending from a laboratory blood sugar standpoint towards diabetes. And we've called out pre-diabetes because it's a wake-up call for people to pay attention to their lifestyle and their blood sugar.
Mike, soda pop has a lot of sugar. Should we eliminate it from the diet? And what about diet soda pop?
Yes, we should eliminate all soda pops from our diet. And after this show, my brother's going to call me up not very happy with what I just said, because he likes his Mountain Dew. But yeah, we should. That's just got no place, really. The diet sodas, I think some people say there's no nutritional value to that, and there's always a question about what is a sweetener in there. There's some people with dietary intolerances to artificial sweeteners. So in general, I would just say stay away from anything except for carbonated water.
Hutch, your active practice, both of you guys are in oh, you all are, I think. What do you do if you see someone experiencing low blood sugar and dizzy, faint, etc.?
You try to get them some sugar, some calories. And the easy way to do that is with a little orange juice or a piece of candy in the pocket. And then you want
Do you have some handy in your clinic?
For sure.
I wouldn't know where to look.
Yeah, we have kits that contain little glucose-containing solutions that we can squirt in people's mouths, yes.
Gentlemen, this has been interesting. We did not get to medications. We really need another show. It'd be fun to have you all back, and then we should look at all of the new drugs and how they affect kidneys and so on. I want to thank our panelists, Dr. David Hutchinson, Dr. Jason Wall, and Dr. Mike Van Scoy, and our medical school volunteers, Tommy Gentle, Katie Johnson, and Linda Liskowitz. Next week, please join Mary Morehouse for a special mental health edition of our program on stress and anxiety. Thank you for watching, and good night.